We are in Chicago and we're talking about, the rate of sudden cardiac death during exercise is very low, but it plays a prominent role in the perceived mortality risk for athletes, and it generates a lot of public concern. So as the approach to pre-participation screening is currently, shall we say, inconsistent and vigorously debated, more information is really needed regarding the etiology of sudden cardiac death among athletes of varied ages and from different populations. Towards that end, in the May 10th issue of JACC, there is a paper entitled Etiology of Sudden Death in Sports, Insights from the United Kingdom Regional Registry. And I'm with one of the co-authors of that. Dr. Sanjay Sharma is an MD and Professor of Clinical Cardiology and Cardiovascular Sciences at St. George's University of London. First off, back up a second. Why did you end up doing this particular study, which was a fascinating analysis?
Well, one of the issues about sudden cardiac death is that although it's certainly high public profile, the actual incidence of death is very, very low. And there is a lot of contention whether we should be spending a lot of money to identify athletes who may be at risk. So we felt that one way of looking at this is to actually identify the true causes of sudden death to inform decisions as to how many of these would be picked up with pre-participation screening, and in how many cases you would need probably the use of an AED. So what we did was we took advantage of our sudden cardiac death registry. We have the largest sudden death registry in the United Kingdom, and we cover most of southeast England. And out of that, we picked out 357 consecutive athletes who had died. 69% of these were actually competitive athletes who played in organized or individual sports. And the average age was about 29 years old. And we looked at the spectra of conditions that cause sudden cardiac death. And one of the things we found was that 40%, or in fact I would say specifically 42% of all our athletes that died had a structurally normal heart, suggesting that in these cases the cause of death was probably an inherited or congenital electrical anomaly that may well be picked up with an ECG if ECG was going to be involved in pre-participation screening. Whereas the world often believes that the commonest cause of sudden death in sport is a condition called hypertrophic cardiomyopathy, we found that hypertrophic cardiomyopathy only made up 20% of all sudden cardiac death in our athletes. Right. So our study showed, firstly, that most deaths are due to electrical faults that may be picked up with ECG screening. And the second thing that our study found was that the two conditions that are most commonly associated with exercise-related sudden cardiac death are, one, arrhythmogenic right ventricular cardiomyopathy, which is pretty well established, and secondly was a rather novel pathological entity called idiopathic left ventricular hypertrophy, whereby the heart has a large mass, it's hypertrophied, and there is some scarring, but there is none of the histological hallmark of hypertrophic cardiomyopathy, specifically myocyte disarray.
So what are you learning from this? What do you think is the clinical message here?
The clinical message is that the vast majority of athletes actually die from electrical faults of the heart that could be picked up during life. The second point is that the conditions that are most commonly associated with exercise-related sudden cardiac death are arrhythmogenic right ventricular cardiomyopathy and idiopathic left ventricular hypertrophy. So what we're trying to say is that ECG screening will probably pick up a very large proportion, firstly, and secondly that there is this novel entity called idiopathic left ventricular hypertrophy which we need to investigate in more detail. Is this just a variant of hypertrophic cardiomyopathy, or is this something that could be acquired due to intensive exercise, where the heart becomes abnormally enlarged, or could it be something completely different that needs a further study?
All of the patients that you looked at, all of the cases that you looked at, were there some where you really couldn't figure out what was going on?
Well, in 42% of cases, there was nothing wrong with the heart. It was structurally normal. And based on studies we've done in the past, certainly in our sudden cardiac death victims that come, when families come to our clinic, we have previously reported that if you've got a victim of sudden cardiac death where the heart is structurally normal and you go back and test their first-degree relatives, you normally find evidence of a hereditary electrical fault in around 52% of individuals.
But you didn't necessarily do that this time, so you can't necessarily say that, but that's what your past experience tells you.
Certainly, yes, that's absolutely right. Our past experience has told us that 52% of people with structurally normal heart, at least 52%, have a condition, a hereditary condition with an electrical basis that could cause a fatal arrhythmia.
I talked at the very opening about the debate that has been going on for some time. You guys take a very different approach to it than we do here in the United States and throughout Europe, actually. You are more aggressive in some of these pre-exercise, pre-participation screenings. What should be done? Based on what you've now discovered in this particular paper, where do you think this leads us in terms of that great debate?
Well, the big debate is between history and examination, which is what the AHA recommend, versus history, examination, and an ECG, which is the ESC viewpoint. Now, before I answer your question specifically, I should say that the Americans do have this customary screening program that's been around for over 5 decades, whereas although the ESC endorse ECG screening, it's important to emphasize that most countries in Europe do not perform pre-participation screening. So if we are going to be looking after athletes, and we are the ambassadors of our athletes, and we're looking at high-profile athletes, then if we're going to do things, we should do them properly, and we should include the ECG, because the current AHA model has a specificity of less than 45%, because the vast majority of athletes have no symptoms, and physical examination will not pick up these electrical faults that I've been alluding to today.
So if you have any more interest in this particular topic, as the debate is going to go on, I suspect, for quite a while, please check out the May 10th issue of JACC, because it really does have this interesting paper and an editorial comment to boot that gives you an idea into just what they're reporting here in this particular case over in the UK. For Cardiol Source World News and Cardiol Source World News Interventions, I'm Executive Editor Rick McGuire.